integrity of the lung endothelium. When you lose them, you have an unstable endothelium. And the cells that interact with that endothelium are going to be activated in some form or fashion, or at least altered. On the other hand, you have lungs are actually a major site of platelet production in the body. About 50% of platelet production actually occurs in the lung endothelium, right along the lining of the capillaries of the lung. And this has been demonstrated recently by UCSF researchers in mice. And I'm sure there's studies going on in humans, hopefully, but and on top of that, we know about ACE2 receptor, but there are other receptors where this virus interacts with, and one of them is CD147. It's not unique to SARS-CoV-2. Other viruses also employ this, receptor, and CD147 simply activates, platelets and megakaryocytes. This is a paper, kind of discussing that, and I won't go into details, but I'm happy to share the slides with the group to kind of dig into it further and further. We do know that platelets play a major role in ARDS, and they can have a protective role or an injurious role. They can actually wall off the pathogen and prevent further injury to happen, or they can become superactivated and actually contribute to tissue injury as opposed to necessarily protect down the line. Platelet activation, as I said, could be very protective in ARDS, but it could also lead to tissue injury. And simple antiplatelets may not regulate the immune action of platelets. You have a thrombotic action of platelets, and then you have platelets that act mostly as immune cells. And the lung platelets are known to be mostly, exhibiting immune function as opposed to, predominantly act as clotting, mediators. Now, can a viral pathogen result in heightened state of platelet activation? Yes, there's plenty of examples. Dengue is one. Does every pathogen access the same reservoir of platelets in the body? No, depends on the site of entry. Dengue, mosquito bite, activate circulating platelets, not necessarily predominantly activating the resident lung platelets and megakaryocytes. In COVID, you have a virus that happens to access the platelet reservoir in the lungs, and that's where we see the majority of the injury happen. Has SARS-CoV-2 been shown to cause heightened platelet activation? Absolutely, without a doubt. There's 4 studies and counting. These slides are from 2 months ago. There's at least 5 or 6 very high quality studies, and some of them are listed here, showing severe platelet activation in response to SARS-CoV-2 infection. Is there anything unique about the platelet activation in COVID-19 ARDS? And this is the crux of the whole argument here. The answer is yes. And I will share with you a slide that we have in press, and it's going to come out in the next week or 2, hopefully. We went ahead and compared COVID-19 ARDS to non-COVID ARDS, and we looked at platelet hyperreactivity to one agonist, thrombin, but the other agonists also behave similarly. The paper just kind of briefly went over the thrombin one. And if you look at the top,
could you expand that slide a little bigger? I'd like to look at it for a second. If you can't, that's okay. Just let us study it for just a second.
Not a problem. I think this is probably the largest I can do on the screen, but the most important part is the top row. And if you look at COVID ARDS, to low dose alpha thrombin agonist, there's far more platelet hyperreactivity compared to non-COVID ARDS. And the non-COVID ARDS cohort included bacterial pneumonia, included ARDS due to cardiac disease, post-cardiac surgery, carbon monoxide poisoning, other viral injuries. It's not a very large scale study, but it's more of a proof of concept here that you do have a very different response. And if you look at the red column here, the red column is COVID-19 without ARDS. So these are more mild to moderate cases that have not progressed to essentially a severe case with ARDS and respiratory failure. You have the same degree of platelet hyperreactivity in those patients as you do in COVID ARDS. And there's a clearly significantly different level of platelet hyperreactivity in non-COVID ARDS. It's far less. As an extension to this platelet hyperreactivity, you're going to get a bunch of platelet mediators released. There's no way around it. When your platelets are activated, you're going to get thromboxane, which is this C. You're going to get platelet factor 4, which is D. You can see the difference between the gray and the top, rows. And on E is where my focus is the serotonin, the plasma serotonin. You will degranulate serotonin out of platelets into the plasma, and it will essentially cause a very elevated and a sustained elevation of plasma serotonin for probably 2 to 3 weeks in this disease in the most severe form. So this is kind of the crux of the whole talk. And, I'll kind of run through these a little bit faster in the interest of time, but do we know how COVID causes heightened platelet activation? It's most likely multimodal. You have efficient access to resident lung platelets. It's very efficient via the ACE2 receptor. You have direct activation via CD147, which has been demonstrated. You have some molecular mimicry, and I'll show you a slide on that, that causes activation of platelets and megakaryocytes. And I think the most important one is really the autoantibodies. That's what's coming out more and more and more is platelet autoantibodies or endothelial autoantibodies. Just came out 2 more papers in the last week that showed this in vivid detail, where they injected plasma from patients with severe COVID into samples, and the plasma itself caused platelet activation. So there's something.
Tom,
go ahead.
Tom, you've been emphasizing this all along. Go ahead.
Yes. Yeah. So, and I think the bottom part is where my focus will be. This is the molecular mimicry slide. Again, I won't go into details, but the spike protein has motifs that are similar to coagulation factor, platelet aggregation receptor, von Willebrand factor. This was, I believe, in Lancet, if I'm not mistaken.
Mm-hmm.
And essentially back to the practical stuff. Well, how do we address all these kind of platelet activation that seems to drive severe COVID and fatal COVID? Many studies have shown a lot of things go wrong from the time patient starts getting infected to death, but really what separates this fatal versus non-fatal cases is the degree of platelet activation and megakaryocyte activation. And these are some of the interventions, that are available to us that are being trialed, obviously. Anti-platelets, serotonin modulation, as Steve, has mentioned over and over again with the SSRI. At least one mechanism of action would be the SSRI, serotonin modulation, and then the others would be the sigma receptors. To inhibit netosis, dipyramidol, and then to kind of calm down the endothelium would be heparin and avoid ventilator-induced lung injury and other things.
Mm-hmm.
It is my belief, and I will present some evidence on that, and Dr. Rolla can talk more about it, that the thrombi themselves and the platelets themselves causing clots is part of the story. The other part of the story leading to fatal disease is the mediators from this very, very exuberant platelet activation. And these mediators, one of them is serotonin, and it's ubiquitous, and it's very widely active all across the body, but completely forgotten, to be honest with you. We all know about serotonin in the brain, and we just don't know about the rest of it. So I kind of broke it down into this slide, looking at mediators of pathology in COVID-19. You have the virus activating platelets, you have the virus activating endothelium, and they feed off each other. The more you activate the endothelium, the more you activate platelets. It just goes back and forth in this cycle. And if you have autoantibodies to platelets, well, this cycle just becomes super fast, and super intense. Then you have platelet leukocyte aggregates such as nets, and then you form thrombi on one hand. But really the important part to me is on the left-hand side. You have to deal with platelet mediators. You can't just, declot the lung and not deal with all of these mediators that are released, as in this slide. So with the antivirals, you target, this box a little bit, but a lot of patients show up very late. They don't show up where we can actually block the virus effects. The platelets and endothelium are super injured And most of these severe cases have, autoantibodies that are already driving the disease. We're not going to stop that by giving antivirals. It can help, but then that's why remdesivir is probably not doing so much for severe disease. Anti-platelets, obviously a focus of study on recovery and other trials, but there is thought process that they should be able to help to some degree. Dipyramidol focuses on.
That would only work if you got it early, right?
So once you have autoantibodies, and the question really is, which antiplatelet is gonna work on immune function of platelets, not so much the thrombotic function, because that's what we're dealing with. These resident lung platelets are very active immune cells as opposed to just clotting cells. So we just simply don't know which antiplatelet is going to do that for us. Dipyramidol has the added benefit of preventing netosis. The oral anticoagulants will prevent the thrombi on the right side, but they really don't do anything for anything else here. You just prevent clotting, but all of these platelet activation and the mediators are going to be there. And that's why we're seeing DOACs fail in observational studies. There's really no good data showing, Xarelto is preventing disease or severe disease or mortality. And, lastly, heparin, it's helping. The studies will show it will help eventually in randomized trials. I know there's some kind of hesitation on that, but most people are on higher doses of heparin. And it will prevent thrombi, it will stabilize the endothelium, thereby stabilizing platelets because of that. And it will really take care of the right side of the picture. My own parents got COVID. I got them on Lovenox 40 once a day from the first day, and they had the mildest disease possible. It's because you just prevent this cascade of injury to platelets, to endothelium, feeding, eventually forming autoantibodies, because the body's like, what are these things circulating? I don't like these. I'm going to form autoantibodies to these endothelium fragments that are released everywhere.
Now, how are you dosing the heparin?
Well, I just gave them Lovenox 40 once a day. I always give this example. If you're a homeless person, unfortunately, getting admitted for placement, which means we just need to find a place for you to go. You're in the hospital for 2 days, you get Lovenox 40 a day without any disease, like zero disease, because that is what we do to prevent, clots in the hospital. If we just kind of, given that benefit of the doubt to COVID patients, which has been shown to be a pro-clotting, pro-thrombotic disease, if we just treated them like a homeless person admitted for placement, from early on, a lot of this injury would be prevented. That's my personal opinion. That's how I treated my own family, but, we're not there yet in terms of the studies showing that. Heparin and antiplatelets would be more beneficial. Heparin and antiplatelet and lung protective ventilation to prevent ventilator-induced injury, which further contributes to the endothelium platelet activation. That would be even better. But this is where we are in this pandemic. I want to focus on these slides. We have late presenters. We have people showing up on no therapy from home, usually on day 10, once the autoantibodies are activated. And all of these are red. There's some thrombi, there's platelets that are super active, there is endothelium that's injured, been shown in many studies. And then you have a bunch of platelet mediators that are just, accumulating more and more and more. Even patients on, Xarelto or anticoagulants from home, they're going to have the same story. They just may not have so much thrombi, they may not have a lung embolism or clots, but they have all the rest going on. They have the platelets that are super active and the platelet mediators. And this left side becomes a problem. You have a clinical problem because you have high burden of platelet mediators circulating in the body. Same thing with a patient in the hospital that comes in late and we put him on heparin for a few days. And yes, we're dealing with all the right side of this graph, but we're still not doing anything for the left side, the high burden of platelet mediators. And what are these platelet mediators? This is all the stuff that's in platelets. It's a lot of stuff. The most unique one, in my opinion, that's causing havoc in COVID is serotonin. The reason is this, and I will go slow on this. 95% of total body serotonin is inside platelets. Only 5% circulates in plasma and in other, storage organs. So if you have hyperreactive platelets with the slides that I showed you, then you're going to have a florid release of serotonin. We know that. That's a fact. That happens in heparin-induced thrombocytopenia. That's how we measure, whether somebody has hit heparin-induced thrombocytopenia is the serotonin release assay. This is not, foreign, this is not some rocket science here. The added problem is 90% of reuptake of released serotonin depends on a healthy pulmonary endothelium. The same area that's injured so heavily because of the virus, and that's been shown over and over again. New England Journal, Ackerman, you can just name study after study in major journal showing endotheliitis of, COVID. So you have lots of release and you can't clean it up. You can't vacuum it. So what you're going to get is this. This is actual patients' plasma serotonin. The bottom graph on the right, you have the blue dots, which is normal patients with normal levels of plasma serotonin, which is always very low. That's how the body likes it. And then you have severe and non-severe COVID. Look at these red dots. This is pathologic. This serotonin is not supposed to be circulating for 2 weeks like this in your body. Extension of that is the slide I showed you, which hasn't come out yet, but it's in press, and the question we got from this slide was, well, how do you know other ARDSs don't do this? Well, we said, okay, well, we're going to go measure it. And we did. And the other ARDSs don't do this to this degree. So this is unique about COVID-19 because of the degree of platelet activation. What does excess plasma, serotonin do? These are the signs of serotonin toxicity, from classic serotonin syndrome. A lot of these we're seeing in COVID. A lot of it overlaps in other ARDS and sepsis causes, but there are a few that are very, very specific, such as ankylosing and hyperreflexia. So, you have, agitation and hallucinations that are very common in COVID patients. You have myoclonus and hyperreflexia, which per NEJM and another study, 67% of severe COVIDs present with myoclonus and hyperreflexia. Are we checking on that? I can reassure you we're not doing that much. Dr. Rolla is, but a lot of other folks may not be checking ankylosing and hyperreflexia. The New England Journal series, 67% had it. Severe diarrhea. Anybody here in this group that's taking care of COVID patients on a regular basis will know how bad this is. I'm a gastroenterologist, so I get consulted on it. It's severe profuse diarrhea. Really, really high fevers. And then the pulmonologists in this group know very well what inappropriate hyperapnea in this disease is. You have patients breathing 40 to 50 times per minute for no clear reason. They're not trying to blow off CO2. There's nothing else going on. This is the most staggering damage that happens in COVID-19 patients. This is why people are dying.
Is that because of damage to the endothelium?
It's a direct effect from serotonin. So we have damage to endothelium from other disorders. We just don't have such profound degree of hyperapnea or rapid respiratory rates. Serotonin, however, in human studies, and I have all sorts of slides to show you, in human studies and whatnot, if you inject serotonin in the plasma, the action of serotonin on the carotid sinus causes tachypnea and hyperapnea. It's been shown over and over again since 1950s. There's nothing new there, but I've been screaming that, kind of like Steve Kirsch, I've been screaming a little bit emotionally too, that please just look at this. This is nothing, earth shattering here.
But why the SSRIs are effective, eh?
We'll get to that in about 2 minutes. So this is the slide on the tachypnea, carotid sinus, why you have such rapid respiratory rates in these patients. And how do we modulate serotonin in the body? You either can vacuum the serotonin out of platelets before the cat is out of the hat, and that's your SSRIs. That's your early SSRI or chronic SSRI. Those are the same Cerner patients with fluvoxamine chronically who are not having severe disease. It's been demonstrated over and over again that SSRIs deplete plasma and platelet serotonin. That's a common misconception. People feel like, well, SSRIs should jack up serotonin levels. They really don't. Now, tricyclic antidepressants do. MAOIs do, but not SSRIs. SSRIs vacuum the serotonin out of your platelets and your plasma, and instead will have antidepressant effect because of BDNF and other hormonal things and other receptor things in the brain that are overexpressed once the serotonin is depleted from the platelets. Or if the cat is out of the hat, you have to antagonize the liberated serotonin with cyproheptadine to prevent all of this. And we are seeing prevention of a lot of this, or treatment or management of a lot of this with cyproheptadine with a few doses.
Well,
and on top of it,
cyproheptadine is an antihistamine, is it not?
It's an anti-serotonin. It's a 5-HT2 antagonist plus antihistamine. And the histamine effect is actually extremely important too, and I'll get to that if we have time. But these effects, for the most part, are mediated by serotonin, not histamine. Some of the lung effects of what's happening in COVID most likely is mediated by serotonin and histamine, but the rest of it is just serotonin here. And on top of it, you have to avoid things that worsen serotonin. Again, for 6 months, just like Steve Kirsch, I have been doing my part emotionally sometimes, trying to tell intensivists to please just don't use fentanyl. Use morphine, use some other analgesic. Fentanyl is a very common culprit of serotonin syndrome, even before COVID. You have options. It's called morphine, Dilaudid, hydromorphone. You use whatever else you want, just don't use this. And we do see patients who are taken off fentanyl, and some of these symptoms get far better. So in terms of the SSRI question, real quickly, this is a graph of platelet serotonin on top, liberated serotonin in the bottom. As the disease severity increases toward the right, platelet serotonin degranulates and serotonin in the plasma increases. And this is probably where bacterial pneumonia is on this line. Non-avian influenza, H1N1 influenza does a little bit more platelet activation. We know that for a fact from a Utah study from 5 years ago. Compared to bacterial pneumonia, H1N1 causes far more platelet activation. And we have not compared head-to-head H1N1 versus SARS because we don't have cases, but we did compare SARS ARDS to other ARDS, non-H1N1, and you saw the graphs. The platelet hyperreactivity was far more. And once you get to a level of liberated serotonin that's super high, in severe disease, you're going to have serotonin-induced multi-organ failure, which is essentially, all these signs here. Okay. Yeah. So yeah. SSRIs deplete platelet serotonin. Boom. If the platelets get activated in severe disease, you'll have a far less degree of serotonin liberation.
Well, now a classic SSRI is not going to be able to keep up with it by itself. Is that why you're using cyproheptadine?
No, it's a matter of timing, sir. So here's the timing of SSRI benefit. If you catch the patient before day 10, which is what Angela Rearson at the WashU is trying to do, and what Steve has, help funding and all sorts of.
Yeah, I've been trying.
Yeah. So this is the issue. Now, the California factory where everybody took fluvoxamine early, because you caught them on this red box here. You caught them early, My parents were on SSRI when they got COVID, and I doubled up on it because we knew when they got it, and it was very, very early. They had, again, along with the Lovenox, they had the mildest disease, and they're in their late 70s and 80s. So if you catch them at this early stage, you can vacuum the platelets, serotonin out. But unfortunately, right where we are in this pandemic, we're not catching them there. We're catching them in the blue box there. People are showing up to ER when they just can't breathe anymore, or they're having super horrible diarrhea or fatigue or lethargy or renal failure. Who knows? We're not getting them on the left side as much as we want to.
Well, Human has been showing that cyclosporin actually works in the blue box as well.
Right, and there's a lot of different immunomodulators, and like I said, we don't know how to modulate the platelet immune function. It may be cyclosporin, it may be SSRIs actually, which I think that's part of it. SSRIs do have data in influenza ARDS. We're not groundbreaking stuff here. There is clinical data, at least animal data, showing benefit in influenza ARDS with SSRI, treatment. And essentially what we're trying to avoid is this serotonin surge in the plasma. However we want to do it, either vacuum the platelets out with early SSRI or as Dr. Rolla gets them in his ICU, he gets them in the blue box. Nobody shows up, in the ICU outside of this blue box. They're all in multi-organ failure usually, or at least pretty severe respiratory failure. And it is in this box where you have to directly antagonize this clearly obvious liberated serotonin that we're seeing.
So what happens if you just use an SSRI at that point? You just can't vacuum it up fast enough, or why?
That's the problem. That's exactly the problem. I mean, again, Dr. Rolla can chime in, but we have 2 days with these patients, 3 days, 4 days. I mean, they're
Right. So
crashing.
it's too little, too late. It's helpful, but it's not good enough. You need to
Right.
basically stop it from having an effect.
Yeah,
Right.
after the granular platelets have broken and the serotonin's on the run, you can't keep up with it at using a conventional SSRI. Now, I've always
That's the
seen
only problem.
cyproheptadine as an antihistamine. So it also is a vacuum for serotonin?
No.
No, it's a direct 5-HT antagonist. It's a direct 5-HT2 serotonin Sec2 type receptor antagonist. And again, I don't know if we have time to go through this, but these are all the slides I've gathered on
Take about
why.
10 more minutes. If you got about 10 more minutes.
No problem. I'll show you some of the data on where the dots connect. New England Journal, COVID-19, 67% of severe cases have ankylosing hyperreflexia. Physicians in this group will tell you there's 2 things that cause that: a spinal cord injury or serotonin syndrome. I'm pretty sure 67% of patients are not having spinal cord injury, coming to the hospital. This is very specific sign. And another series, larger, 64% have ankylosing hyperreflexia. 54% of them persisted until ICU discharge. This ain't going away. This keeps happening. And patients actually come back to the ICU for not necessarily the respiratory failure. They'll come back because of tachypnea or rapid respiratory rate. They come back because of agitation, hallucination. We see it every day. They're not on much oxygen.
Yeah, this is a classic case of what's being experienced in the long haulers. Is that correct?
So my impression of the long haul is you have this lung who's stunned with so much serotonin that it had to clear up. And my belief is basically you express so much SERT or serotonin, transporter in the lung endothelium. Remember, that's where serotonin gets cleared, is the lung endothelium. You express so much of it that you essentially have an overzealous, overactive serotonin vacuum in the lung. So essentially you have a shortage probably of the serotonin. But I have no evidence to prove it, but that's my impression. Is a lot of these patients they appear to be having signs of probably a depleted serotonin state. And the second source of serotonin in the body is the mast cells. So then you get an overactive mast cell, condition where the mast cells are trying to make up for the tissue serotonin that's lacking. That's why a lot of these patients have mast cell activation syndrome. They respond to Pepcid and Zyrtec, but the root of the problem is not gone. The brain fog persists because the mast cells truly are needed to be there to kind of make up for the serotonin. If you calm them down, well, you get a lot of mast cell symptoms go away, but you still have the brain fog. You have some of the serotonin depletion symptoms still going.
So is there also, I'm concerned about the potential damage to the endothelium in the lung endothelium.
Absolutely.
Also,
It's there.
Yeah.
It's there. There's no doubt about it. And there's been studies that have shown that, the pulmonary microvasculature, even in long haul patients, they've imaged them very carefully and in detail. And there seems to be some ongoing issues with the pulmonary, microvasculature. Cyproheptadine prevented blood-brain barrier breakdown and prevented, reduction in cerebral blood flow in this study. That was induced, serotonin-induced blood-brain breakdown and reduced cerebral blood flow. Cyproheptadine prevented it. Another study, same thing. Cerebral vasogenic edema was prevented by cyproheptadine. Now, do we have evidence of blood-brain breakdown in COVID-19? Yes. 3 out of 8 patients studied in this series had it. Do we have evidence of cerebral vasoconstriction, reduced blood flow in COVID-19? Yes. On the left, RCVS and PRESS-like, manifestations of COVID have been documented over and over again.
And then the vasculitis is also an issue as well, is it not?
Right. So what serotonin does in the cerebral microvasculature is it constricts it like hell, and it breaks down the blood-brain barrier. Again, on the left, reversible cerebral vasoconstriction syndrome and dissection in the setting of COVID-19. These are happening, and probably a lot of it is happening. We're not just recognizing it because we're not imaging these people, to be honest with you. They're in the ICU. Vasogenic edema, series from COVID-19, lots of that is seen on MRI, and everybody's just scratching their heads wondering, well, what's going on? We don't know. It might be the virus. It might be this. It might be the inflammatory storm. No, there is one molecule that does all of this. You don't have to go too far. COVID-19 renal failure, reduced renal blood flow despite normal cardiac function. Again, a study out of shock. It's been shown in excruciating detail that that's what happens to the kidneys in these patients, is they have a constricted renal artery. Now, does serotonin do that? Yes, 5-HT2, which is the same receptor as cyproheptadine. Another study, this actually shows 5-HT1 mediates vasodilation, so we don't want to target that. Another study showing 5-HT2 causes renal artery vasoconstriction. Dr. Rolla and I have evidence that with one dose of cyproheptadine, we have been able to improve renal artery blood flow in these patients in COVID-19 with one single dose. So there is a serotonin pathology, at least partially there. Again, more evidence on the renal artery. I won't bore you with details, but this study came out with the COVID-19 diarrhea. It's actually mediated by serotonin. They actually measured serotonin in patients with COVID-19 with severe diarrhea versus the ones that don't. And the difference is the plasma serotonin. And the second difference is the lung cannot break down the 5-HT. So you have low 5-HIAA, which is the breakdown product of serotonin. So in those that have high serotonin and poor breakdown, which is exactly what I try to demonstrate there for you, you have high liberation and you have a lung that cannot clear it, then you're going to have severe diarrhea. In these patients, we have severe glucose abnormalities. Almost all of them are on insulin drips or something along that line because we cannot control their sugars. And serotonin causes hyperglycemia, peripheral serotonin. Again, I won't bore you with the details, but.
Farid, is there any possibility that serotonin is implicated in damage to the beta cells of the pancreas?
So intracellular serotonin modulates insulin secretion from pancreatic beta cells. Landmark study that came out a few years ago.
Gosh.
So cardiac serotonin mediates netosis, in the cardiac microvasculature. Do we have evidence that cyproheptadine reverses refractory coronary vasospasm in these patients? Yes, there's one study. Here's a second study. Do we have COVID-19 patients who get cardiac catheterization because of a STEMI and their coronaries are clean? Yes, I had one patient with it. There's many reports of it. So there's no major clot in there. It's just coronary vasospasm is what we think is going on. And cyproheptadine prevents these. Marker for coronary microvascular dysfunction, plasma serotonin.
Take about 5 minutes.
Again,
Well, he's got about 65 more slides here.
Yeah.
I'm done. I'm almost done.
About 5
Lymphopenia of COVID-19. Could serotonin cause lymphopenia? Yes. There you go.
Hey, for
Can
Farid,
macrophages be?
okay, quick question. So say you're a long haul COVID patient. You've had COVID, for 2 months now. You still have the COVID symptoms. Which would you use an SSRI, or would you use a cyproheptadine, or would you use both, or something else?
So I have a friend who has really bad long COVID and very, very prominent athlete, actually. He tried cyproheptadine, things got worse. Tried SSRI, things got worse. So now he's trying tricyclic antidepressant, which is the absolute opposite. They're actually going to raise the 5-HT, the serotonin. Both SSRI and cyproheptadine essentially effectively reduce, the 5-HT that's circulating around. So that's my N of 1. It's an anecdote, but my belief is the tricyclic antidepressants will prevent the overzealous breakdown of serotonin by these lung microvasculature who have been stunned 9 months ago to clear all this serotonin, please, because serotonin is toxic to the lung. It causes pulmonary hypertension. It causes pulmonary fibrosis. Your lungs are going to respond to it. They're going to overexpress, cleanup crew to essentially clean this up, but I don't have any data to kind of show you that that direction is correct.
So he hasn't tried it yet.
Yeah, John Preston, we need to get this to your friend.
Yeah, he hasn't tried. I think he might be trying it like these days. I haven't talked to him yet, but I've had other people who've been on TCAs and they've had a good response.
Wow.
Some
Yes.
some haven't.
That's so anti, that's counterintuitive.
I agree with you. The whole thing, and the problem is the serotonin physiology is completely forgotten, Steve. That's the problem, is nobody knows this stuff. But this is all elaborately detailed. You know, on platelet aggregation, 5 more minutes.
Yeah.
5-HT,
Steve,
it leads to
Steve, I
platelet
worry,
aggregation.
Go
I
ahead,
worry
John.
a little bit. I worry a little bit though that if you reactivate serotonin, you might propagate the tendency that the lung has to over mediate it, and so it's complex. There's no
It is.
really easy answer here for the long haulers.
Right.
Absolutely, I agree with that.
We don't, yeah, we still
I
don't
agree
have
with that.
enough data on what's really going on here, but at least we have some now sort of a novel thing to try that I never would have thought would be effective. I mean, it's completely counterintuitive.
And lastly, just 5 more slides. Platelet aggregation is mediated at least as a weak agonist by 5-HT. Again, studies citing this. And shock is mediated by serotonin. I encourage everybody to read this study. It came out 2 years ago. Very elaborate study done on platelet-released serotonin due to immune complex essential activation, which is exactly what's happening in severe COVID. And this study essentially tells us exactly what's happening in COVID, and it goes into extreme detail. But serotonin mediates shock in this disease, and we have started people on cyproheptadine, and their shock completely resolves. You know, in COVID-19, they completely get off pressors within 2-3 doses. Not everyone, but
So what happens if you give it too early? Like, you know, why wouldn't you add this to an SSRI and say, hey, great, you know, 1-2 punch, and we'll really.
That's a great question, and I think the idea is the cat out of the hat yet or not? You kind of have to pick. I'm guessing. Is there side effects to this medicine? Not really. I mean, it causes a little sedation, just like Benadryl. That's all it does. I give it to outpatients for cyclic vomiting syndrome without hesitation. These are not COVID patients. But to answer your question, Steve, this is a study that looked at the lung vessels. And most important thing is serotonin is an extremely potent constrictor of lung microvasculature, which is, you know, essentially, you know, in this, in this study, if you guys read it, you'll see exactly what happens by platelet-released serotonin. It constricts the lung microvasculature extremely. And to answer your question, how early? This study looked at the lung microvasculature at the smallest levels. And they saw that you have, on the left-hand side, you have extreme microvascular constriction without having the classic pulmonary infiltrates of COVID, which you see on the right. So very early on, this disease most likely starts as an extreme vasospasm of the lung microvasculature, even without the GGOs and the pulmonary edema and the infiltrate. I can't overemphasize how important this study is to the whole concept, where this starts. So Steve, you may be right. We might need to give cyproheptadine when patients, you know, are on the left-hand side CT as opposed to the right-hand side CT. We're just not there yet in terms of data and efficacy. I simply don't have any even anecdotes to tell you that this prevents it. But we do have anecdotes to tell you that when patients on the right-hand side over there, cyproheptadine is reversing at least 25% of the patients.
You know, they tried to SSRIs for asthma, which didn't prove to be all that effective. But I wonder if is this also effective in asthma?
Good question. There's some, I can send you some articles on the serotonin role in airway hyperreactivity. There is some signals there. Has it been used, you know, in clinical practice? I don't think so.
Thank you.
Okay, go ahead. We need to wrap up. And this is really, really important stuff. I'd like you to continue this discussion.
This is amazing, Deck.
Yeah, this is great.
Really,
Yeah, I mean,
really
it'd be great.
amazing.
Maybe you can share it, as you said, if you're willing to share it, maybe even on your site, Steve.
Yeah. Well, and
Yeah,
Again,
I would like a copy of this
yeah,
slide.
I definitely want a copy of this deck.
no problem.
Please.
I will send it.
And
I will
I'd
send
also
it
like
to.
a copy of the recording of this presentation as well, Steve.
yep, I'm actually, I should have let you know, I am recording it. And Philippe has just said that he's got it in his blog, but I'd like to revisit this in a future meeting, maybe in a couple weeks, because I think that there's so much here to digest. I want to go into it in more detail.
Absolutely.
Yeah, yeah, me too.
The bottom line, though, Steve, is get that SSRI in very early.
Yeah, yeah. Well,
Yes.
I really want to find out what Philip Parola has to say about the use of cyproheptadine in ICU, because that's a big concern.
By the way, did you record my session as well, or is it just this one?
I think I did, but yeah, I have to.
So,
I've limited competence, as you know.
so I believe Dr. Rolla had to go to another meeting. Unfortunately, 5 minutes ago, he just texted me and I didn't notice it. But
It looks like he's
Um,
on.
he's on.
I'm here.
Bill, do you want to go ahead?
Yeah,
Please.
sure. Yeah, I've got my other simultaneous department meeting going on my phone, so I'll just take a few minutes though. First of all, thanks for inviting me to this group, and thanks for the help. I think thanks for this amazing work that you guys are doing all over. This studies and others. I think it's fantastic. I'm the chief of my ICU at Santa Cabrini Hospital, which is a community hospital in Montreal, Canada. Unfortunately, I'm not shackled by all the things that a lot of academic centers are. And fortunately, I'm someone who likes the cutting edge. And I have to say that, Steve Kirsch, you're spot on in that most doctors are exactly like what you described. And that, and whoever had commented about your approach, I found it really, really fun. And I have the same, for having been teaching a lot of cutting edge stuff for the last over a decade, the resistance to change is immense. The inertia of physicians is immense, partly because part of it has to be with recognizing that what they've been doing to date is inadequate. And that's a really hard pill to swallow for most docs. So that's why you're going to get a lot of resistance with that approach, but I love it anyways. So in terms of the use of cyproheptadine in my patients, like I'd said, Farid and I, recorded a podcast a few months ago. I've been speaking to Farid since the first wave. I think the mechanisms made sense to me. And so I decided to use it initially on anyone who had clonus, essentially, because I'm only going to get the patients who are already dyspneic, agitated, a bit confused. That's all par for the course. So clonus is the one that made the difference. And maybe a month and a half ago, when I first started using, there was a couple cases that, I was like, oh, this one's delirium, confusion, and clonus and respiratory problems turned around faster than I would have expected them to, because, we know that no matter how deep the course of their COVID, respiratory failure goes, it lasts for a certain time. It's not like a pneumonia where, they get their antibiotics and a day or two later they pop out and they leave the ICU. Even if they never need to be intubated, they're kind of in for a while. And I had a couple cases that really turned around faster than I would have expected, which is what kind of made me say, this could be good. And a lot of the inflammatory markers did go down. So enough for me to say, hey, I think it's worth using, because essentially the side effect profile is minimal. And essentially none, because a little bit of sedation in these ICU monitored patients is no big deal. The other thing that I did do also related to serotonin is stop using fentanyl altogether. And I just used Precedex, dexmedetomidine, Precedex, and other opiates like Dilaudid or morphine or whatever. And I found that we actually have a lot less. And all essentially now my last week in the unit, everyone was on cyproheptadine. And I only run a pure COVID unit. And there was a lot less fever, a lot less agitation, a lot less all of that than, my memories of the first wave. Because in Montreal, we had a first wave back in March, April, May. It quieted down by June, and we didn't get really hit again till, about a month ago. So really quite different. Even nurses were commenting, oh, there are less fevers, there's a little bit less of everything. So all, not enough to publish in New England, but a signal enough that I think it's worth doing a study on this. Yeah.
Thank you, Philippe. I do want to revisit this, and I'd invite you to continue to participate. I'm going to reach out to you and to Farid separately and discuss ways that we can do this. Anybody who would like to join me, I'd like to set up a separate meeting and call, and then I want to bring it back to the Thursday meeting, perhaps in a week or so. And Philippe, I really want to get your input on temporary or transitory ICUs, the design of those. We really need them. And you've got some insights that I desperately need. I need to move on now to Dr. Eisenagel. I'm sorry, I mispronounced your name. If we run a little bit long, that's okay. I'd like to invite everybody to stay on if you can. And Dr. Eisenagel, go ahead. I wanted to get your presentation in. Especially given the fact, hopefully Pat Cochran's still on, and I know Tom Hodges, and your insights with respect to T-cell impacts, I think, would be very helpful.
Okay, well, thank you.
Go ahead.
Incidentally, everybody just calls me Ice.
Okay, ice, baby.
Yeah. So hopefully this will work.
It looks like it is. Bingo.
That's amazing, because I am somewhat technologically challenged here. Well, there we go. All right. So when we spoke a couple of days ago, it was really in relationship to this paper that I have in Frontiers in Immunology, where I was questioning infection, whether these manifestations are infection or autoimmunity. And just for everybody's knowledge, I'm actually a cardiothoracic surgeon, and I am not doing COVID care. So one would ask, why are we spending 20 minutes listening to me? But this comes from my experience in heart transplantation and mechanical heart. And I was director of a program up here in Spokane for 25 years. And prior to that, I was assistant professor at the University of Arizona for 3 years. And just by way of declarations, unfortunately, I have nothing to declare.
Okay.
So why is a heart surgeon talking to you? Well, in the early days of heart transplantation, there were only 5 heart transplant programs in the country. And the first successful use of mechanical assist devices was back in 1985. And in that era, the transplant surgeons were providing nearly all of the medical care. And we followed that at the University of Arizona, and we did the heart biopsies, we read the heart biopsies, and we gave the immunosuppression. And that model continued on when I came up to Spokane. And there's my 25-year record. That was compiled by the Medical Data Research Center at Providence, showing that even surgeons sometimes can come up with survival curves that beat the international average. But back to COVID. Back at the University of Arizona in the mid-1980s, we had 3 young women, 2 with infants, who presented with severe cardiogenic shock after having a short-term viral illness. And all of these young women died despite mechanical support. And of course, they were coming to, of all people, the cardiac surgeons, essentially the mechanical doctors, because they were in such severe cardiogenic shock. At autopsy, their heart biopsies showed severe lymphocytic infiltrates with myonecrosis. And for those who are interested in myocarditis and the history of it, this was basically met the criteria of myocarditis by what was called the Dallas criteria after a conference that was in the mid-80s or so in Dallas. And here is such a patient of mine, and this is how they present. histologically, you have these dense lymphocytic infiltrates. And, but if you were to take this biopsy and show it to a heart transplanter, they would say, you have severe cardiac rejection. So the histologic picture is basically identical between cardiac rejection and acute myocarditis in patients with Dallas criteria. So that brought us to the question, can a virus cause you to reject your own heart? Now, in the world of sort of medical guidelines and mainstream medical thought, I think most cardiologists would say, or at least the upper echelon of cardiology would say, well, this is a cardiotropic virus, a virus that infects the heart, that damages it, that then causes this severe destruction. However, there's evidence from the basic science literature that this is an autoimmune process that's initiated by the virus. If we look at what the literature was clear back in the 1980s to what it is today, the treatment for this is basically still supportive care. So in January of 2020, there was another sort of position paper from, I think, the American Heart Association on how we should be treating fulminant myocarditis. The authors emphasized that these were not guidelines, but suggestions from experts. And my basic supposition here is there's been no advancement in the clinical management of myocarditis over the past 30 years. But if we go to the basic science literature, and this is where I started off with this, I had these patients dying on me and I had no idea what to do. And since there wasn't anything in the clinical literature to guide me, it was off to the library to have the librarian, at that time there was no Google, search for articles on myocarditis. And Jack Woodruff in 1974, then at Cornell, established that T cells were critical for the pathogenesis of myocarditis in a mouse model using Toxicity B3. And he showed that while the virus might be present in the heart, the T cells were actually the mediators of tissue damage and not the virus. Now, Dr. Woodruff died sudden cardiac death at the age of 45, right after he published this study. One of his grad students, Dr. Sally Huber, went on to the University of Vermont, and in 1984 showed that when she would take these T cells out of these infected mice with myocarditis and then put them in a monocyte monolayer that was grown in tissue, these cytotoxic T cells would then destroy the monocyte monolayers. And this really defined that viral myocarditis, at least in this model, was an autoimmune disease.
So I need to understand that because that's pretty profound because we are seeing an awful lot of myocarditis as a consequence of even asymptomatic exposure.
Yes.
That's pretty profound. Wow. How do we fix that?
And note, this is all old literature.
Wow.
This is old stuff. Then Dr. Huber, 1986, showed that if you gave anti-thymocyte serum to the little mice right before and after you inoculated them with the virus, you had no myocarditis. And
is how reversible is myocarditis?
I'm going to show you it's really reversible.
Okay.
At least I hope to show you that.
Okay.
Okay, so here's some of the interesting stuff. At that time, Jay Mason, who was at the University of Utah, as I recall, did a wonderful study on looking at cyclosporin. Did cyclosporin along, I think, with prednisone help in myocarditis? And there was a big negative study. And then later on, IVIG was used to treat adult patients with myocarditis in a big and negative. Again, it was a negative study. So the literature on the randomized prospective trials have been two big negative studies. Now, interestingly enough, Dr. Gilbert, who was at the University of Utah, as I recall, used the first monoclonal antibody that I think was manufactured, OKT3, which was an anti-CD3 antibody. And we used this in transplantation as for induction immunotherapy. Had some efficacy in viral-induced myocarditis. So the patients all had a viral prodrome, but this collection of patients had all kinds of other therapies also involved. But there was a brief spurt in the literature where a number of programs looked at using OKT3 for T-cell depletion in myocarditis. And that was reviewed by Blinska in 2007. That basically showed that there were 10 studies showing some efficacy for T-cell depletion in myocarditis. Now, we started a protocol, I think back in 97 or so, perhaps even earlier than that, where we would treat patients with RATG, another one of our classic transplant medications. It's RATG is rabbit antithymocyte globulin, and it is made by taking human thymocytes and injecting them in rabbits. Then you harvest their serum and purify it, and you come up with this collection of antibodies against a variety of thymic epitopes. And it primarily is a big T-cell killer. It has all kinds of other activities, but it's primarily a big T-cell killer. And we showed that when we gave this when a patient would come to us in cardiogenic shock with myocarditis, and here we have a little bit about this protocol. Patients would come to us and they'd be very, very sick. And if they were acutely ill, not the patients who just present with heart failure, then we did an immediate heart biopsy on them. And we would give them RATG 1.5 milligrams per kilogram per day for 3 days. And on the first dose, we also gave them 1 gram of solumedrol. And the reason for that is, well, we always give solumedrol whenever we give a dose of RATG to a transplant patient. And then we found that most of them got nearly immediately better. Now, some of them were so sick that they required mechanical assist devices, but the main goal was keep them alive until the T-cell killers can do their thing. We then did post-treatment biopsies and demonstrated that these lymphocytic infiltrates then went away. But because of the patients, the patients, who come to me are always on death's doorstep. And a number of them have severe multi-organ failure at the time that they come in, and they're moribund, and there's not that much that can turn somebody who's that close to death around. So when you look at T-cell depletion in myocarditis, there are no randomized controlled trials. And I went through almost all of the reviews on myocarditis over the last 20 years, and it's very rarely mentioned, with the exception of giant cell myocarditis. But what we're doing here is we're treating a type 4 hypersensitivity reaction. That is a reaction that's induced by T-cell overactivity. And so that is the way we went along with treating myocarditis. However, for those of you who are familiar with the literature, a number of patients, in fact, probably the majority of patients with myocarditis, don't have any infiltrates on their heart biopsies. And here is one such patient of our series. And she was 45 years old, had a viral prodrome. She came in very unstable. And you see there in the second line, from the onset of her first heart failure symptoms to the implantation of a percutaneous LVAD was only 12 hours. And I would say to the residents on who are around at the time that when you have one of these young, particularly young women with autoimmune myocarditis, you need to consider them on the equivalent of being a gunshot wound to the chest. You need to run to the emergency room, not walk. And so we went down there, grabbed her out, and did an immediate heart biopsy on her. And by this time, our protocol had changed a bit. We gave her 3 milligrams per kilogram of RATG. But then the biopsy came back showing no cellular infiltrate, and the patient was not better. Keep in mind that most of our experience with the ones who had a cellular infiltrate, they're better nearly immediately. And so we presumed her to have an antibody-mediated myocarditis, which is a type 2 hypersensitivity reaction. That is, that virus induces an antibody production, which then turns out to be harmful. Now, at about the same time, the University of Utah, again, a major leader in cardiac transplantation, demonstrated long-term antibody-mediated cardiac rejection, and did a number of papers on that and helped elucidate this mechanism. Also, in our basic science literature, Dr. Maisch, I believe from Austria, demonstrated in a murine model with Coxsackie B3 that the virus induced an antibody that would then go to the heart, go through the outer membrane of the myocardial cell, traverse across the cytoplasm, go into the outer mitochondrial membrane and attach to the adenine nucleotide translocator on the inner mitochondrial membrane and stop that enzyme from working and essentially deprive the myocyte of energy, and the heart would stop. So by that time, we had a fairly decent idea of, hey, these antibodies induced by viruses can really kill you. And that was evident to even surgeons. Oh. So we had, by that time, developed the protocol for antibody-mediated myocarditis, and then we would give them rituximab, and we did that, but the patient was still not better. And we felt that we needed to get rid of the offending antibody, and therefore we would give them plasmapheresis. And this patient got a total of 6 treatments of plasmapheresis beginning on March 26th. But note how she's going downhill in the meantime. She went downhill so far that we had to place an RVAD on the 25th to keep blood flowing from her right side to the left side. Her aortic valve stopped opening by echo on the 26th, meaning this heart is basically stopped. But the 26th was also the beginning of our plasmapheresis. And as soon as we started doing the plasmapheresis and getting rid of those offending antibodies, her heart started to beat again. And we were able to take out the RVAD on the 30th. And then she recovered enough to have her LVAD removed on the 4th of April. And by the time she eventually was discharged, she was back to normal. And we had a series of patients.
Is the plasmapheresis excorporeal?
You bet it is.
Yeah, that's what I thought.
Yeah, so here's the idea behind what we are trying to do. The virus is inducing a severe type 2 hypersensitivity reaction. And a lot of this is reviewed in this paper that I've written, but for sake of time, we're generating low affinity antibodies that are probably not even class switched in these early days after we're getting these viral infections. And these antibodies are being secreted by plasmablasts that have a very short half-life. Now, when you give RATG and rituximab sort of together, we know that the RATG will delete T cells, activated M memory. Curiously enough, RATG also has an antibody against CD27, which is the phenotypic marker of a memory B cell. But it does not have really strong anti-T cell activities. It has some. Now, rituximab is an anti-CD20 monoclonal, which is a phenotypic marker of a naive B cell. But as those naive B cells mature, they lose that marker. But the combination of these two drugs together, you basically delete the T cells, memory T cells, the naive B cells that are going to come through and eventually become memory B cells. And you do also have an effect on memory B cells. So this does a sort of short-term deletion of 2 of the 3 arms of immunologic memory. Now, we know that there are some memory B cells that do not display CD27.
Can I ask a question? Just
Absolutely.
so if you're deleting the memory T and memory B, is that right?
That's correct.
So if you delete the memory T and the memory B, what effect does that have on induced immunity as a function of vaccination?
I'm not sure you want to give this right after you've gotten a vaccination.
Yeah, that's what I'm thinking.
But if you've just been given, if you've just had an infection with a virus that is inducing all kinds of antibodies that are having a negative effect, it's probably a good thing. Now, back to your interesting vaccination question. Let's say you have a bad vaccine and you're getting, what's the term? One of the immunologists help me. That enhanced vaccination response, where you get an autoimmune response.
Tom, you're on mute.
ADE or something like that.
Yes, antibody
Dependent
enhancement. Yes, ADE.
Okay. If you have that, you might think about doing this, but that's an aside. Anyway, so this is what we would do. So here's, I mean, basically, we're trying to get rid of these T and B cells and memory T and B cells so that we can stop this acute immunologic response and the production of the plasmablasts, needs an S in there, doesn't it? Then end. Now, we're hoping that we don't have long-term, long-lived plasma cell clones being produced. We hopefully cut that off before they find a protective niche. And by getting rid of the offending antibodies that are still there, because we haven't done anything to get rid of the antibodies, but that's what the plasmapheresis is for. And that's when you should see the clinical response, is once you get rid of the antibodies. But if you don't get rid of the cells that make the antibodies, then one would hypothesize that the whole process is just going to start all over again.
Just another question, just briefly. And if it's okay, I'll call you Ice, because I love that. John and Tom, plasmapheresis is excorporeal, so is Seraph 100. Would the Seraph 100 be the equivalent of doing plasmapheresis here?
It may be. I was just thinking that same thing. because we know it pulls out anti-nuclear antibodies, so it would probably pull this out as well, these out.
Yeah,
I would be,
yeah, in short, this filter mimics the glycocalyx and has heparin sulfate binding sites. So imagine a filter that about the size of a Coke can that has, 1,000 times more heparin sulfate binding sites than the body has. And so it tends to bind with things that like heparin sulfate, like, almost all pathogens. And Jan Kielstein on this call right now has been using it quite successfully to treat COVID patients, as have a number of other doctors.
Jan, go ahead.
I would be a little bit more cautious about the SARAF because when you do plasma exchange, and we did this in several settings, like donor-specific antibodies after heart transplantation and lung transplantation, the idea is, and for that reason, I really like the pathophysiology, to get the IgG and other immunoglobulins down very rapidly, and then with a pharmacological treatment at the same time, prevent that they come back. So you combine an immediate effect on the immune system with a pharmacological effect that kicks in a little bit later. Indeed, the most effective way, and this has been tried with patients with dilatation of their heart due to beta-1 receptor antagonists, they respond very nicely to immunoabsorption, and the immunoabsorption gives you a much more higher clearance of immunoglobulins. So usually in plasma exchange, you exchange 1 to 1.2 times of the plasma volume during one treatment. So we are talking about maybe 4 liters. With immunoabsorption, where you have the plasma and then you have a secondary circuit that clears the plasma from immunoglobulins, you can treat as much as 12 or 15 liters of plasma in one session. Even though I'm a big fan of the SARAF, and I was wondering what the SARAF does to serotonin, so we will hopefully piggyback on that and do a freezer study. I'm not convinced. I'm not convinced we can that effectively modulate immunoglobulins. Yeah, a little bit more caution from my side.
Yeah, let's explore this maybe in the next week or so, because I'd like to look at the serotonin reuptake inhibitors in the context of taking it out directly. That's a brilliant idea. I like that. I just don't know.
Yeah, I was thinking the same thing, Steve. I think that this texted John while they were talking about that. And I think serotonin may come out with this filter.
Yeah. Yeah, keep going, Ice. And for folks, we're way past time, but let's keep going. I appreciate it.
Okay. So these myocarditis protocols started off as IRB approved protocols. And then eventually the IRB became tired of looking at this year after year. And keep in mind that very few patients ever present to any one given center. And so that makes it extremely difficult to really do a randomized controlled study because you just don't see enough of these patients. But when they do come in, they are just gripping emotional and medical disasters. And so the question then becomes, well, does SARS-CoV-2 induce these same autoimmune pathways that have been seen with other viruses that induce myocarditis? And we've found that there were a whole variety of viruses that were the causative viruses over the 20-something years that I was doing this. But these are just type 2 and type 4 hypersensitivity reactions that are described in other viral infections. And so my feeling was, well, this is just more of the same that we've seen with other viruses. Just COVID does it more frequently.
Is Coxsackie B is that a beta corona?
No,
No.
it's
What is it,
I think
Tom?
it's an enterovirus. Isn't that correct?
Yes, enterovirus. Yes.
Okay.
Now,
When we're
Coxsackie
asking a
B.
cardiac surgeon what kind of a virus, we're out on thin ice there. But
Well, obviously, so
anyway,
by the way, Alex, it's at 4 o'clock, Alex.
all right. So T and B cell depletional therapies have not been investigated despite evidence from the basic science literature that has shown some efficacy. And when we look at some of the clinical manifestations of COVID-19, particularly HLH and MAS, we've seen there are other studies that show that the T cell depletional therapies have been efficacious in both of those clinical scenarios. So while many of these agents, and this has been brought up earlier in Steve's comment, they have corporate sponsorship because of obviously there is a financial opportunity to find out if your medication has another use. But these monoclonal antibodies are really sort of small weapons. But compared to the blunt tools of the old historic blunt tools of cellular depletion, they're just a small tool when you perhaps need a bigger tool. And so we've just submit that further investigations of T and B cell depletional therapies for COVID-19 are warranted. But of course, these kinds of studies run up against the hurdles that have already been mentioned of, well, these are not going to be money-making therapies because they're all off patent. These are the kind of studies that government has to do. As I recall, the study showing efficacy of Solumedrol was from the British Health Service, not from any companies that are making steroids. So there are big hurdles, but and the manufacture of these kind of medicines required a considerable ramp up time if they were found to be efficacious in COVID-19. But I think that they're worth consideration for those who are on the front lines. And that is it.
I have a question. If these are autoantibodies or T cells directed against some antigen, do you think it's because of molecular mimicry of the virus, or is there something that the virus does to the cell that makes a particular protein or a structure to become foreign?
Yes and yes. From what I know of this virus seems to have a number of polypeptide chains, which are identical to polypeptide chains in the human proteome. And therefore, I think that increases your chance of having molecular mimicry issues.
Well, the other piece of the puzzle from the last talk, if this virus is indeed a CD147 agonist, CD147 agonism will activate a number of leukocytes, including T cells and B cells, as well as antigen-presenting cells.
Right. One of the other unique features of this virus is its interaction with, blank on it, Ice, interferon 1 and 3, isn't that correct? So the virus has escaped these basic cellular antiviral strategies.
Yes.
And this allows it to keep on stimulating the cell, but the virus is able to escape these mechanisms, and so it can keep on growing and stimulating, but does not get the appropriate antiviral response.
Yeah. We have done homology studies, ICE, and have not seen that much similarity between the human genome or human proteome and this virus. There's some similarities. Scott, are you still on? Scott, I guess he had to go. But Scott has done an extensive search and has found very little similarities between the virus and the human proteome. And so I'm thinking more in terms of this causing damage to the cell that results in proteins being recognized as non-self, and that's what you're seeing. Is there any particular protein in the heart that would be recognized by these antibodies, you think? Do you know of one?
I don't know of that. The thing about antibodies is that you can generate millions of kinds of antibodies, and it's difficult to identify which antibody is being produced and to what epitope it is active against.
Yes, I know.
Now, in the world of transplantation, we were blessed with the ability to figure out what our antibodies were because they were largely against HLA-1 and 2 molecules. And so we are able to follow our therapies to see if they're actually being effective by just looking at our Luminex studies over the course of time after you've given these things.
Yeah, well, that would be because of the rejection, I would say, the HLA.
That's
type.
right. So,
Yeah.
but in this particular disease process, who knows what the antibodies are actually against? We have some evidence for some antiphospholipid antibodies, but the number of potential antibody configurations is enormous.
Yeah.
And perhaps some of the other investigators can give us some idea as to how we are progressing with being able to identify antibodies and their epitopes.
I was just struck by the comment that you said that these patients looked like they had their hearts were being rejected.
That's
That's
right.
good.
It is the clinical picture when they show up with us is very rapid downhill decline, frequently within a few hours. An example that everybody in the family is sick with the sniffles and or whatever. Dad leaves to go to work. Mom is home taking care of the kids. He calls home to see how mom is doing. She doesn't answer the phone. Dad comes home early, like at 2 or 4 o'clock in the afternoon, and mom's on the floor unconscious.
Yeah.
And the patient who comes in with, I feel horrible all over, to the emergency room. Well, you've got a cold. There, go home. And then she has an acute decline and she might get back to the emergency room or may not. Yeah. Again, patients, whenever you have a cardiac surgeon who's taking care of somebody with an autoimmune disease, you're in deep trouble. Yeah. But these patients would come to us, and as I explained earlier, there's nothing in the conventional medical cardiology literature that says this is how you should handle them. But we came up with these protocols based upon our experience, or based upon looking at what our basic science colleagues were doing now decades ago.
You know,
Very interesting.
I'm really struck by a couple of things that I think are very profound. One of them is that if you can eliminate memory T and memory B, that is so counterintuitive to me. It would seem like that you'd want to do just the opposite. But I'm wondering for different symptoms, if that is the appropriate thing. And I guess coming back to the question about myocarditis And I need to get your old colleague Bobby on the phone, Bobby Robbins. I know Sangeeta, I think Sangeeta's still on, maybe not. I was going to say we need to recruit more of Bobby's team from U of Arizona. You were a U of Arizona guy, is that right?
That's correct. In the old days when Dr. Copeland was the director there.
Okay, well, but the question I have comes back to the excorporeal use of plasmapheresis. Now that's a chromatographic approach, is that right?
No, it is not.
Is it filtration?
My understanding is it's basically a filter.
Well, maybe I can chime in here because I'm with the International Society for Apheresis to disclose that. So what you basically do, you have you pull out the whole blood and you separate it either by centrifugal means or by a large bore filter, and then you just throw away the plasma.
That's correct.
And you substitute it by either an albumin solution or by donated plasma. The main difference is, of course, in the setting of surgery, you know, rejection of organs immediately after surgery, you want to go for plasma due to the coagulation factors in it. But the other beauty about the plasma is that you have the good old friend ADAMTS13 in there, our cleaving protease that takes care of the von Willebrand multimers forming. And that is the reason that for specific indications where you not just want to get rid of something, you use the human plasma as an exchange fluid. And you do a procedure that lasts maybe 90 minutes, and you can exchange about 1 to 1.5 times of the plasma volume during that period of time. So that removes about 60% of your circulating IgG. So this is the kind of measuring stick that is usually used for the plasma exchange procedures, but of course you do much more than that, and we combine industrial strength pharmacotherapy with plasma exchange in many diseases that involve the immune system. In ANCA associated vasculitis, we have this approach to use plasma exchange and stiff immunosuppressive therapy like rituximab or other drugs in combination. And this buys you time because you have an immediate effect that you then can combine with a longer lasting but longer needing effect. So you can fill the gap by the extracorporeal procedure. And I really like that view, and I'm really humbled that you know, again, a cardiac surgeon has to point to that. It never crossed my mind because I had this tunnel view on the disease, and I never thought about this potential implication for the heart problems we're facing with COVID.
Well, once again, the Thursday meeting comes through.
Well, I wish to thank you for inviting me to share my experience, and I certainly appreciate the other investigators' insights into this disease. And I just want to thank you for sharing, and I've learned a lot today.
Well, thank you, Dr. Eisenagel. I feel uncomfortable just calling you Ice, but I'll do it anyway. I hope you'll continue to join us. Most of the doctors on here are regulars, and your insights, the whole thing about this Thursday meeting is to just, as Jan just said, sharing insights And I think we're mutually discovering a whole bunch of things that are that merit exploration, I think. So I want to continue this particular conversation further. So Pat Cochran is on as well, and you guys can swap hellos while you're at it. So
Yeah, Tim, it's good to see you. It's a great job. We go back
Well,
so far. I didn't
Matt,
know
where are you nowadays?
I'm in Mississippi. I'm doing locums too. So,
Oh, okay.
But I came here to help out on transplants, and then they changed directions. The chief left, so I've just gone back to locums. But Tom Hodge and I have been friends since grammar school, junior high. So we've known each other forever. Great job. Let's touch base offline.
Okay, great.
all right, well, let's keep this going. We've gone a half an hour past, and it was well worth it for me. So next time around, Tina, I don't know if you're still on. Tina may have left, and Steve Lawless may have had to go as well. But Steve is an MD that also does stuff in risk management. Tina is going to talk to us a little bit about the risk management issues, or how to mitigate liability exposure for surgeons who adopt new practices, and that may help alleviate some of these concerns. Farid, I'd very much like to thank you, and Philippe, or do you go by Philip or Philippe? I really appreciate your participation. I hope you'll continue to join us. And as usual, I learned a lot one more time. So we'll see you all next week.
Steve, be sure and send me Farid's talk, please. I want to share it with some people.
I'll do that if I can figure out how to extract it from my computer.
Okay, thanks.
Thank you. I would like to have that. Do you have a website where we can extract the talks?
Not yet.
I need to do something. I have to confess that this started off as a 4 or 5 of us got together, Upendra and Tom and I and John, and it's kind of exploded. So
Yeah, Steve, following up with on our talk with Sheila Stewart, and I think we'll just go ahead and create a website. So we need to first figure out the name of what we're going to be. So I'll work with you and Tom offline and see what we can come up with. Okay.
Let's do that. We need that.
We do.
It will be ironic if we are unable to cure SARS-CoV-2 because Steve Winston was unable to figure out how to get a recording. Yes, we had the solution, but he couldn't figure out how to get the Zoom recording to us.
Steve, I think both you and I will get really emotional if that happens.
Oh, finally. Finally, Sean. I got you on my side.
All right.
I just shared the link in the chat for when Farid and I recorded his presentation a month ago or so.
Yeah, it's already on the repository, my repository for fluvoxamine. Thank you.
Awesome, guys. Thanks. I'm hoping that the government will step up to some of the things it hasn't been doing. I hear there's a change in management.
Yeah.
I've heard about that.
Yeah, I actually started breathing again. So wasn't there a movie called Waiting to Exhale or something like that? I don't know what the heck it was. It was probably a romantic comedy or something. And of course, a romantic comedy I would never see.
Yeah, before that, we had to inhale a lot to get through that. So
it felt more like turn your head and cough.
I love it. Great session today. Farid's talk was particularly instructive.
Yeah.
Steve, I actually kind of believe your data now.
Yeah.
Really? Oh, finally. There you go.
Yeah. Love it.
All right. So
right.
Steve, I'll help you present your data because I think I know how to get your audience more interested.
Yeah, you have to make my slides more boring.
Alex said it's at 4 o'clock your time.
Okay, thank you.
All righty. All right. Well, thank you, everybody, and we'll just
Thank you.
keep on trucking.
Bye-bye.
Bye.
Bye-bye.
Very good. Bye, everyone.